Talking about European guidelines, what are the blood tests in assessment of patients with a stable coronary artery disease?
Thank you very much. I think the routine blood tests that we do if we're looking at patients with stable coronary artery disease is we first look at the hemoglobin. Does the patient have anemia or not? Because that can already be a cause of chest pain rather than stable coronary disease in itself. So if you transfuse the patient, then probably the work is already done. That's one. I think you need to look at the kidney function. That's very important. You want to assess also the liver tests, because if you're going to give medications such as statins, they might have an effect on the liver functions that you measure in the blood. And you therefore want to see the baseline values so that you can interpret the follow-up values if a patient has complaints. The other thing that you also want to do, and that's probably the most critical, is the lipid spectrum. Because we believe that if we treat patients with coronary disease, that the fundament of this treatment is statin therapy. So we then need to know what is the total cholesterol spectrum. So what is the total cholesterol, what is the HDL cholesterol, and most important, what is the LDL cholesterol. And then we can assess that before and after the therapy of statins. So these are the blood tests that we routinely assess in every patient.
When exercise electrocardiogram is recommended?
Actually, that is one of the cornerstones of diagnostic approaches to patients with stable coronary artery disease. If they're very low likelihood, pre-test likelihood, less than 15% pre-test likelihood, we don't do anything. It is very likely that this is not coronary artery disease. If they have a very high pre-test likelihood, more than 85%, basically the patient goes straight for coronary angiography and we don't do tests. So it is the field, the whole spectrum between 15 and 85% where we need to do some form of testing. In those patients you could consider to do an exercise test. Nowadays when we have non-invasive imaging exercise tests, we like to have one of those because we also see the effect of the ischemia on the blood flow in the heart, in the myocardium, and also the effect on wall motion. Alternative markers of ischemia. An exercise test is a very good starting point, but we should also realize that it has a lower sensitivity than an imaging test.
And is coronary CTA an alternative test for the diagnosis of stable coronary artery disease?
I think CTA is a good test in terms of ruling out coronary artery disease. If we do a CT angiography and we see the coronary arteries and there is no atherosclerosis, no stenosis, no calcium, the patient does not have coronary artery disease of the large arteries. There is no effect of the cholesterol in terms of forming stenosis. The problem occurs when the patient rules in. If you show atherosclerosis, then the next question comes, is this atherosclerosis flow limiting? In other words, is there ischemia? And based on that, we probably, if we see a lot of atherosclerosis, we need a second test to confirm or exclude that there is ischemia, and that will be used as the gatekeeper for invasive angiography. So, nothing on the CT scan is ruling out coronary artery disease. If you see abnormalities and they're significant, then probably you either go directly for invasive angiography if it's a very high-risk CT scan, or you do an ischemia test to determine if there is yes or no ischemia. If there is yes ischemia, you go to the cath lab.